This is a case of intraocular lens exchange involving removal of a single-piece acrylic eye-enhanced lens. This patient flew from New Hampshire to Austin because she was bothered by negative dysphotopsia, but overall was in good focus and saw objectively well. So we first create one, or in this case, two secondary incisions with a 1mm sapphire blade. Then we infused 1% non-preserved lidocaine for anesthesia. OcuCoat is then used to optimize our view and then infused into the anterior chamber. A 2.8mm diamond keratome is used to create our primary incision. Then a Donnenfeld spatula is used to elevate the anterior capsule from the IOL. Then Helon GV is infused to viscodissect the IOL optic and haptics from the capsular bag. The eye-enhanced haptics, in this case, are liberated from the equator of the capsular bag without difficulty. Then we use the viscoelastic cannula to bring the IOL haptics and optic into the anterior chamber. We use 23 gauge MST micro holding forceps to grab the edge of the IOL. Then we use 19 gauge Packard-Chang IOL cutters to bisect the IOL, which is free floating in the anterior chamber, protected posteriorly and anteriorly by a cushion of Helon GV. Careful attention is made to not inadvertently nick the anterior capsule. One tip is that the micro holding forceps will adhere to the lens optic, so we use the IOL cutters to help separate the optic from the forceps, which allows us to remove the forceps from the eye easily. Then the 23 gauge micro holding forceps are used to remove each half of the eye-enhanced single piece acrylic lens. We rotate the second half of the implant to an orientation that allows the haptic to fold back as we pull it through the primary incision. The second eye-enhance is then inserted into the capsular bag. Viscoelastic is removed from behind the IOL and from the anterior chamber. I prefer to rotate the replacement IOL haptics into the same location as the haptics of the original IOL, if possible. Now, if we were doing routine intraocular lens exchange, we would then hydrate the incisions and the case would conclude. This patient, however, is having an intraocular lens exchange for treatment of negative dysphotopsia. In order to treat her ND, but keep her in focus with minimal alteration to her refractive status, we chose to remove her 23 diopter eye-enhanced single-piece acrylic lens and replace it with a 22 diopter eye-enhanced lens that was placed in a reverse optic capture configuration to alleviate her negative dysphotopsia. To perform her reverse optic capture, we fill the eye with Helon GV, then use a Connor wand to lift one edge of the lens optic up and then tease it such that the edge of that optic is anterior to the anterior capsule. And then we use the Connor wand 180 degrees away to perform a similar maneuver, lifting the lens optic edge up and anterior to the anterior capsule shelf. Now the single piece acrylic implant haptics remain in the capsular bag while the lens optic is anterior to the anterior capsular rim. We use a Kugelin lens manipulator to verify that we have secure placement of the optic anterior to the anterior capsule. And then finally, to remove the viscoelastic without altering the position of the implant, we choose to not use coaxial irrigation and aspiration and instead infuse balanced salt solution into the anterior chamber and flush out the Helon GV through a 27 gauge cannula. We're able to express the cohesive Helon GV from the anterior chamber and then seal the incisions with stromal hydration. So this patient maintained her plano refraction while her negative dysphotopsia resolved with this procedure. So hopefully this video gives you a few tips on how I remove a single piece acrylic lens during routine intraocular lens exchange. Thank you for your time and attention. Have a wonderful day. Bye-bye.